covering treating cardiovascular inflammation and making the argument that it's clinically actionable now, and also discuss the current and future landscape of anti-inflammatory therapies for atherosclerotic cardiovascular disease. My name is Paul Ridker. I work at the Brigham and Women's Hospital in Boston. I have a variety of conflicts as shown here. This is a very exciting time for the clinical translation of the inflammation hypothesis of atherosclerosis under the leadership of Dr. George Mensa, who is a lifelong scientist at the National Heart, Lung, and Blood Institute. Just a few weeks ago, the American College of Cardiology put out its 2025 ACC scientific statement on inflammation and cardiovascular disease. And Dr. Mensa's fundamental quote you see at the top argued the evidence linking inflammation and atherosclerotic cardiovascular disease is no longer exploratory, but is compelling and clinically actionable. The time for taking action has arrived. That's what I'm going to try to cover briefly in this talk in two parts. Again, following the quotes from the actual document, the first, universal screening of high sensitivity CRP, our biomarker for inflammation, in both primary and secondary prevention in combination with cholesterol, represents a major clinical opportunity and is therefore recommended. I'll explain briefly why. And then the document goes through two therapies, low-dose colchicine and some novel therapies like IL-6 inhibitors, and I'll try to explain that as well. The rationale for measuring high-sensitivity CRP in all secondary prevention patients comes from a variety of studies. I picked our paper from 2023 here, 3 very large contemporary secondary prevention clinical trials that the cardiovascular community knows well, Prominent, Reduce It, and Strength. In all 3 of these trials, the most predictive issue for recurrent cardiovascular events turned out not to be LDL cholesterol, which are the white bars, but actually the high sensitivity CRP reflecting this inflammatory response. That's the black bars. Now, again, I'm a very aggressive LDL lowering physician. We all understand that these patients are already treated with statins. But after the patient's on a statin in secondary prevention, the core question being raised by these data is, what is our next target? Yes, we might add a second lipid-lowering drug, but why aren't we targeting inflammation itself when this is the largest unmet clinical need? Well, that was secondary prevention. What about primary prevention? We also recently published data looking at some 30,000 women followed for over 30 years, and each of these biomarkers, LDL on the left and high sensitivity CRP on the right, measured in a random blood sample nearly 30 years ago, does a very nice job predicting future cardiovascular risk. Yet once again, the magnitude of risk, the spread, if you like, is greater for the CRP than it is for LDL cholesterol. Now, I'm certain all of our listeners measure LDL cholesterol, but as was pointed out in earlier lectures, inflammation adds and is integrated with LDL. We should be measuring both of these, and clearly the hs-CRP is predicting risk at least as well as LDL cholesterol. So we have to get past this idea that the variability here is a problem for us. In fact, we have multiple data, both in men and women, showing this very similar result. So the question became, how do we move this forward into clinical practice? And as Dr. Libby discussed in his opening session of this series, inflammation in the NLRP3 inflammasome is one important target. This is a mechanism by which cholesterol crystals, other crystalline structures activate a particularly important piece of the innate immune system that leads to upregulation of interleukin-1 beta, which has direct effects on the endothelium, as we'll come back to. Also, in turn, activates and upregulates interleukin-6. Both of these, in turn, go to the liver and put out our biomarker, the high sensitivity CRP, which is not a target for our therapy, but it's a very convenient biomarker along with PI1 and fibrinogen, telling us that this inflammatory process is present on a chronic, and I would say silent basis. Now, Dr. Libby and I had the pleasure of designing and running the CANTOS trial several years ago. This is the proof of principle that targeting inflammation per se can lower cardiovascular event rates. The drug that we used was canakinumab, a monoclonal antibody that targets interleukin-1 beta. This was a secondary prevention trial of patients getting aggressive contemporary care, including statin therapy, almost all on high-dose statin therapy. The trial was run in 39 different countries. Over 10,000 patients were enrolled. The trial ran between 2011 and 2017, and basically was a standard trial of very well-treated, aggressively treated secondary prevention atherosclerosis patients who were then added to their usual care, one of 3 doses of this IL-1 beta inhibitor or placebo. And as you see in the lower left part of this slide, we had dose-dependent reductions in the downstream biomarker CRP. We had dose-dependent reductions in interleukin-6, our key cytokine after IL-1 has been blocked. But importantly, we had no change in LDL, no change in ApoB, no change in triglycerides, no change in blood pressure, no change in hemoglobin A1C. So with a target monoclonal antibody really attacking this IL-1 to IL-6 axis, we got 15 to 17% reductions in MACE and MACE+, which is the same kind of reduction we saw from the PCSK9 trials. But remember, the PCSK9 trials deliver that 15 to 17% benefit by dramatically lowering ApoB and LDL cholesterol. We did this without touching ApoB and LDL cholesterol. We simply targeted this fundamental process of innate immunity, showing that we have a whole new way on top of statin therapy to lower cardiovascular risk for our patients. Now, canakinumab is not available to the cardiovascular community because we had an additional quite interesting finding, which was dose-dependent reductions in incident lung cancer. That's not that surprising. Activation of the same NLRP3 inflammasome in the lung among patients who smoke cigarettes is a very important driver of lung cancer. And as you see here, we had placebo on top and then low, middle, and high dose, such that we had a 67% reduction in incident lung cancer with this particular drug. And so what happened here is that the sponsor of this trial, Novartis, decided to move this into the oncology world. There's a lot of very interesting work going on there. But the good news is that today cardiologists can give another proven anti-inflammatory drug, low-dose colchicine. This is the data from the LIDOCO-2 trial, similar to CANTOS in the sense that it's patients with stable atherosclerosis. Again, the vast majority, 97%, are taking statin therapy. The CRP levels, we know on a post-hoc basis, were elevated, so these are patients with residual inflammatory risk. And this trial showed a 31% reduction in major adverse cardiovascular events. Now, I would argue if we saw a 31% reduction with a drug that was promoted by major pharmaceutical interests, all of our listeners would know about this trial already. In fact, there's a second major trial of low-dose colchicine known as COLCOT. This showed a 23% reduction in risk. Again, that was statistically significant. Now, with all anti-inflammatory therapies, we have a possibility of having some adverse effects on the innate immune system. In this particular case, there was a very small risk, increased risk of pneumonia, about a 0.5 percentage point higher. So physicians using any of these drugs may want to look for these kinds of effects. But this means we have 2 large-scale trials of low-dose colchicine already available to us to think about using in our patients on a chronic basis. Now, many of you are aware that there's been a third trial that was canonically reported as a neutral study. This was the Clear Synergy trial. Now, this is a slightly different setup. The prior 2 trials were in chronic stable atherosclerosis, which is where I think colchicine has a good use. This was a trial in acute coronary ischemia, in fact, technically acute STEMI. It's interesting, though, this trial was run before and during COVID. Before COVID, as you can see here, the trial was tracking to be quite positive. It was only after COVID started, when running clinical trials became very difficult, that this trial became neutral. So many of us look at this trial as it would have been positive had it not been for COVID. In any event, most recent meta-analyses that include the Clear Synergy study are telling us there's roughly a 25% reduction in MACE, 20% or larger reductions in ischemic stroke and urgent revascularization. So again, this is a therapy that I think you should think about as long as your patient has normal kidney function and normal liver function, because that's the way that colchicine is metabolized. Now, recently, we've talked about a new issue, which is a concept that we've called Smurfless but inflamed. Smurfs are not just the cute little cartoon figures that we've seen on television. A SMRF in the prevention community is a standard modifiable risk factor. So if you're SMRF-less, you do not have any standard modifiable risk factors. But we showed within our Jupiter trial that we had 8,270 individuals who had no standard modifiable risk factors, yet all had an elevated high sensitivity CRP, again, greater than 2 milligrams per liter. And in this post hoc look at a previously completed randomized trial, SMRF-less patients who are outside our guidelines are largely ignored, and I think will be ignored in our new guidelines, showed a very dramatic reduction, 38% reduction in the primary trial endpoint of MACE, a 69% reduction in MI, a 47% reduction in stroke, and a 39% reduction in revascularization procedures by simply giving statin therapy to individuals who did not have traditional risk factors, but had elevated levels of high sensitivity CRP. However, as we move forward beyond colchicine and beyond statins, why so much focus on interleukin-6? Well, the answer is pretty straightforward. IL-6 sits very central in this process. Activation of that NLRP3 inflammasome, which activates both IL-1, in turn upregulates IL-6. And we showed in a pre-specified analysis from our CANTOS trial that when we inhibited interleukin-1, the magnitude of benefit was greatest among those individuals, as shown on the left, who had the largest reductions in downstream high-sensitivity CRP, or on the right, those individuals who had the largest reduction in downstream interleukin-6. So perhaps interleukin-6 is our best target for therapy. Well, we've had the opportunity to move forward in this field quite aggressively. We worked with a drug called ziltivekimab in something called the RESCUE trial to develop in a phase 2 setting a targeted IL-6 ligand inhibitor that can dramatically lower downstream CRP, much more than we saw in our CANTOS trial where we had a 40% reduction. Here we have 80 to 90% reductions. And we actually have two other entries into this class now, a drug called clazakizumab, which is being used in a randomized trial in dialysis, which also has very similar characteristics. And a third drug that has been recently brought in from Tourmaline Bio that also is an IL-6 ligand inhibitor. So where are we going with this? Well, there are three major outcome trials already launched. I'll take you through quite quickly here. One is called ZEUS, which is among patients with chronic kidney disease where they can't take colchicine, who all have residual inflammatory risk. That is an hs-CRP greater than 2, and also known atherosclerotic disease. One is called Hermes in the setting of HFpEF. One is called Artemis in the setting of acute coronary ischemia. And clazakizumab, the other drug I talked about, is now being used in the setting of dialysis. Well, ZEUS is up and running. I have the honor of chairing this trial. It's over 6,000 patients on a global basis. It's fully enrolled. Again, these are patients at very high risk where we give statin therapy, but the inflammatory response is the main driver of their future demise. And as you may recall from clinical practice, patients with chronic kidney disease are more likely to suffer from heart attacks and strokes than they are to actually progress to complete renal failure. So these, again, are secondary prevention patients, prior history of MI, prior history of stroke. They have elevated hs-CRP, so residual inflammatory risk, and they have quite clear chronic kidney disease, either by a UACR or an eGFR criterion. On top of usual care, half are getting ziltivekimab, 15 milligrams once monthly, half are getting placebo. And we have two endpoints here. One is a primary traditional cardiovascular 3-point MACE endpoint, and the other is an interesting endpoint asking the question, can we also reduce the progression to kidney failure? The second of the ziltivekimab trials is looking at heart failure. This also was an outcome following our CANTOS trial, where my colleague Brendan Everett was able to show, as you see on the left, that CRP levels and IL-6 levels predicted hospitalization for heart failure. And these are the only randomized trial data we have to date suggesting that when we give an IL-1 inhibitor, we get a small but statistically significant reduction in incident heart failure. So the second of these major trials is called Hermes, and this is a much more provocative trial because in the heart failure setting, we have some very new drugs that are being very effective. But again, in this setting, on top of SGLT2, on top of GLP-1s, roughly 5,000 patients will receive either ziltivekimab or placebo, and here the endpoint is a traditional combination of cardiovascular death, hospitalization of heart failure, or a heart failure hospitalization visit. The third new area is in the setting of acute coronary ischemia. We have to date for tocilizumab, a interleukin-6 receptor antagonist, 2 provocative small trials to date looking at non-STEMI and STEMI. Both of these were run by Lars Golestad's group, and I think they both taught us some very important lessons. First, that this approach is safe. There was no evidence of myocardial rupture, and there was some reductions in the area under the CRP curve and area under the troponin curve in the non-STEMI trial. And in the STEMI trial, which is called the SAIL-MI, there were some reductions in surrogate endpoints, such as improved myocardial salvage and reduced microvascular obstruction. And so we have evidence here that perhaps in a large-scale trial, this might be a novel way of addressing risk. So the third of these major trials is called Artemis, again being run with ziltivekimab, being conducted by our colleagues globally and in the United States through DCRI. This ultimately will have over 10,000 patients with their recent acute STEMI and non-STEMI. The goal is about 50% of each type of acute coronary ischemia event. Half will again get ziltivekimab at the time of the acute ischemic event to see whether or not dampening inflammation immediately can help us. And then we're going to follow these patients for 12 months with chronic therapy. And again, this trial is up and running on a global basis with a traditional 3-point MACE outcome, as well as a hierarchy, including, among other things, all-cause mortality. What's fascinating, however, is to watch the explosion of different kinds of anti-inflammatory therapies into this arena. There are drugs that go well beyond what we've talked about so far that are looking at localized inflammation, are looking at innate and acquired inflammation, and we have drugs that have been with us for some time, such as interleukin-2 agonists, JAK kinase inhibitors. Many agents are being repurposed into this arena. I also want to remind you that direct NLRP3 inflammation inhibitors are also becoming prevalent. There are 6 or 7 of these agents that are now in phase 2 practice, trying to find out, can we go upstream? And one advantage of this would be, instead of a monoclonal approach, many of these could be small molecule inhibitors. There's also this whole concept of resolution. This is a recent review article from our colleague at the Brigham and Women's Hospital in Boston, our friend Charlie Serhan, talking about the resolution of inflammation as being a different process than simply the impairment or the inhibition of inflammation. And resolution itself is another way of potentially targeting this process, where specialized pro-resolving mediators have been discussed and are also being evaluated as potential ways to get us where we want to be by targeting not just a lipid component, but also this inflammatory component. So I want to come back to the beginning, just as Peter Libby did in his opening talk, to remind you that Nikolai Nikolaevich Anichkow, who is really our father of the lipid hypothesis of atherosclerosis, because it was his experimental work in 1913 that showed us that feeding egg yolk to certain mammalian species led to atherosclerosis. It's well worth, however, reading his papers carefully, because when one does so, and you can see in his drawing on the right-hand side, he was also describing inflammatory cells, cholesterol-laden phagocytes, macrophage foam cells, endothelial cells, resident macrophages were all part of this process. What we're talking about in this series is the rediscovery of this, that yes, indeed, on top of lipid lowering itself, targeting inflammation is also a future way of dealing with this disease. I believe, and many of my colleagues believe, that combination anti-inflammatory and lipid-lowering therapies will be the mode of the future. But in order to get there, we have to measure hs-CRP almost universally in our patients, as I noted at the beginning, in both primary and secondary prevention. Doctors will not treat what they don't measure. So think about CRP and think about anti-inflammatory therapy.
Well, Paul, thank you very much for that really important message about clinical translation of the biology of inflammation. And you focused a lot on IL-6, and for good reason, because it is being trialed in all of those great studies that you outlined for us. You know, we're making headway in having the community understand CRP. The landmark statement, which just came out from the American College of Cardiology, which you co-authored, has gone a long way towards really resolving some of the issues and addressing them in a way which I hope will take sway with the clinical practice community. But what about interleukin 6? You showed the data from CANTOS that showed that it's a very good predictor of risk when it's lowered and uh, benefit when IL-6 drops. But some of the same issues that really caused some controversy about CRP over the decades apply to IL-6. So is the assay one that's standardizable and available widely? Are there fluctuations in IL-6? Is it a biomarker which you think might even supplant or work in addition to C-reactive protein?
Yes, so Peter, it's a very important question. And actually, our original papers over 30 years ago we measured both CRP and IL-6. And there was a very good reason that we went with CRP as the biomarker of choice. Um, we're going to see lots of papers showing that IL-6 levels on a population basis predict risk. There's no surprise there. The difficulty is the IL-6 half-life is much shorter than CRP, so the variation is actually much wider for the individual patient. And we've shown in our head-to-head studies that while both work very nicely and are highly correlated with each other on a population basis, CRP is simply going to be a better marker long-term for this process. There's also another little twist to this, which I think is what you're getting at. If the IL-6 inhibitors work, and I certainly hope they do, then we have a little problem. If I give an IL-6 monoclonal antibody to a patient with an elevated IL-6 level, you would intuitively think their IL-6 is going to go down, and it will functionally go down. But the actual IL-6 measure, the assay that we use is for total IL-6, which is both free plus bound IL-6. So from a clinician's perspective, giving an IL-6 inhibitor is going to drive the IL-6 up. And I think that's going to be very difficult for the clinical community to wrap their heads around. We don't have free IL-6 assays available to us yet. And until we do, that's going to be a major impediment towards moving forward here. So I think sticking with high sensitivity CRP, levels less than 1 to 3, greater than 3 milligrams per liter, is going to remain our target for this clinical identification. And it's also available on a global basis in a way that the IL-6 assay just isn't. So even though the data are very interesting, I really don't think the clinical side is going to change very much.
Although IL-6 was not a routine clinical lab test, the pandemic changed that, and it was mostly a research tool. But then we learned during the COVID-19 pandemic that IL-6 was a very good and useful marker for prognosis and perhaps for allocating therapy. So it is becoming more widespread, but as you point out, it's not something we're going to be able to use to follow the patients who are being subjected to IL-6 neutralization therapies. Let me go back to the fascinating work that you've done with Gemma Figtree about Smurfless but inflamed. There's a large school of thought in the traditional epi community that really it's the thresholds for counting someone as having a risk factor or not that define Smurfless. And if you actually go with contemporary cut points for the traditional risk factors, that Smurfless is actually a pretty rare phenomenon. What's your comment on that controversy?
Peter, I sometimes think our colleagues in the preventive cardiology community need to sort of wake up and figure out what's really going on here. We've varied the thresholds in that paper up and down, all the way down you could, and you end up with quite a few people who are still in this category, and you have an enormous benefits. I think the idea that Gemma Figtree put forth as Smurfless was a good one for clinical people to think about the fact that there's more out there than just our traditional risk factors. But you can vary blood pressure down quite a bit. You can vary LDL down quite a bit. And you always come up with a lot of people who have events. I think this notion in our current guidelines, at least the American guidelines, that we have certain thresholds of risk are really quite complicated. I think that if you don't measure the inflammation, you just don't know your patient has it. It's just like I can't imagine practicing cardiology without measuring the blood pressure rather than just guessing at it. I can't imagine not measuring LDL rather than guessing at it. I just don't understand why people are going to think they can guess at what the CRP level is, what the inflammation is. I think we have to get past this and recognize that there's a new biology and it's terribly important.
And I think that's what we're here together to try to really elucidate. And I think it's been a great pleasure to partner with you, Paul, not only through the decades and the work that we've done jointly, but also in this presentation to try to raise the consciousness about inflammation is not just a theory anymore, but it's becoming clinically actionable. And we have ways of moving forward to get as smart about inflammation as we've become with traditional risk factors. So thanks so much for joining me, Paul.